Because placenta accreta spectrum is a complex condition, it is important to assess the severity of that condition. And that is done by a number of ways, not just the clinical history, but primarily using ultrasound. And it's when ultrasound identifies a placenta accreta spectrum patient and determines that it's a severe end of the spectrum, that this may be complemented by an MRI scan. So that would only happen in the minority of placenta accreta spectrum patients. And the sort of things on ultrasound that might suggest that an MRI is required would be a low-lying placenta involving the lower uterine segment. It may have a more posterior position. It may be one that potentially involves the parametrium, or there's a high suspicion of hypervascularity in the bladder region and invasion of the bladder. So they'd be all findings that would push it into a high-risk category, and that would be something that would suggest that there would be indications for using MRI scan, which would further substantiate the ultrasound findings and may even downgrade a situation or upgrade a placenta situation to a higher risk situation. And it's only in those higher risk cases that we need the expertise of interventional radiology. There are many different devices we use in our specialty. Everything is pretty much positioned via a small 3mm opening in the skin. And specifically in the case of managing patients during delivery in a placenta accreta spectrum situation, we would position the catheter through the right groin typically using ultrasound guidance, and we would measure up the size of the balloon using what's called an intravascular ultrasound device. And all of this fits through a small 3mm opening. So once we've decided on the diameter of the abdominal aorta, we choose an appropriate balloon. Baby's delivered initially, and it's only after baby's delivery that we would inflate the balloon. And the inflation would only be for several minutes at a time. And this would give the operating obstetricians and gynecologists time to, in a more controlled manner, to dissect away the different vascular structures and allow for a safe operation. Our practice has been for many years now that this would all be done in the operating theatre environment before the patient's put under general anaesthetic. And the portion that's done before the anaesthetic is just getting access into the femoral artery. The balloon, the intravascular ultrasound would be done after the patients has their epidural and or their general anaesthetic. They would only be those patients who have severe placenta accreta spectrum. So it would only be in those small numbers that have a severe type of placenta accreta spectrum. Fortunately, complications are very rare. They're usually at the access point and relate to minor bruising. It would be extremely rare that people would get what's called a dissection injury of the femoral artery that might require surgery. But fortunately, that hasn't happened in our experience.